I now have the great pleasure of introducing our next speaker, Dr. Sue Robinson. So Dr. Robinson is a professor at Dalhousie University, and she is a hematologist at the QE1 Health Sciences Centre in Halifax, and has directed the adult haemophilia program there since she started. So she has a great deal of experience in this area. And she's going to speak to us about quality of life. And while she's coming up, I'm just going to mention a story. We all see the beautiful ads for Newfoundland, and it is very beautiful, and they're all very idyllic, but life in outport Newfoundland for women could be very brutal, and especially with those with rare bleeding disorders. And I have had a story told to me by one of my patients who has severe factor 13 deficiency. So when she was a little girl, of course she'd had relatives who died from bleeding. In the community there was a woman who had a tooth pulled and bled to death, and so when a new doctor arrived in their community, she was about 7, and she told him she was a bleeder because she wanted to make sure if something happened she would get attention, and he laughed at her. So she told me she took out a little knife and cut herself and was hospitalized for 7 weeks, after which he did believe she was a bleeder. And she has factor 13 deficiency, which is very difficult to diagnose, but I thought that would illustrate some of the issues.
Okay, thanks so much. So hang in there. I am going to try to go quite quickly. So some disclosures that aren't relevant. I think I'll jump over my objectives. So I'm going to talk about health-related quality of life, so HRQOL, you'll see in all my slides. So the first seminal paper on this topic was from Canada, Dr. Guyot in Hamilton. And he defined health-related quality of life as a multi-dimensional construct for quantifying patient-perceived well-being and functioning in terms of physical, emotional, mental, and social components. Then a year later, in 1994, the World Health Organization came out with their definition. So these assessments are more focused on how the patient perceives their medical condition, and it's more relevant since a reduced quality of life is typically what will motivate a patient to seek medical care. So looking at these quality of life studies, they started to show in clinical trials in the 1990s as a secondary endpoint, and then in 2000s as a primary endpoint. A number of generic instruments were developed. You'll see them there. The first two were for adults. The PEDS-QOL is a validated questionnaire for quality of life for children, and the last one is for both. So a generic quality of life questionnaire helps the health providers and policymakers understand how bleeding disorders would differ from other chronic conditions or from the general population. But the disease-specific questionnaires, which are what we aim to have more of, are designed to identify issues that are unique and important to a certain condition, and then changes from treatment or disease-specific complications would be better studied or recognized. So for bleeding disorders, the only international validated bleeding score is that for hemophilia. A number of instruments have been developed for adults and for children, and I'll point out the CHOCLAT, and that's been developed in Canada. Lead author, Dr. Nancy Young, in 2006. And this is was also updated in 2011 with a French version, and Dr. Vicky Price was at the World Federation meeting with their updated poster, and now this has been translated in 14 different languages. So this is just an example of the most common generic form, the SF36. And just to give you an example, these are the different domains that you would ask a patient. So for example, vitality, you'd either, your lowest possible score would be you feel constantly tired, and then the highest would be you feel great. But you can see how general these topics are. So just going back and reviewing what's probably already been said, the prevalence of bleeding disorders among adult women with heavy menstrual bleeding is about 10 to 20%. In one study, 13% were von Willebrand's disease. In a more recent study, which showed more than 20%, the majority of patients have platelet dysfunction, and this prevalence is higher in adolescence. At the World Federation meeting, the UK registry was updated, and their top 4 diseases are von Willebrand's disease, hemophilia A, 11 deficiency, and platelet dysfunction. So you can appreciate how many women would have these disorders, and there's the prevalence of heavy menstrual bleeding. And just a word about iron deficiency and heavy menstrual bleeding. So since heavy menstrual bleeding typically will start at menarche in women with bleeding disorders or adolescents with bleeding disorders, this leads to a high risk of iron deficiency, and that is associated with, as you know, multiple negative health issues. So, other bleeding in women that are usually not captured in these quality of life scores, and then this was already alluded to partially, the postpartum bleeding, and I've got the prevalence there from some studies, hematomas, dental bleeding, epistaxis, GI bleeding, other gynecological bleeding, or joint bleeding. So looking at quality of life questionnaires for women with heavy menstrual bleeding, because these were the first ones that were developed, and certainly a major issue in women with bleeding disorders. So in 2008, there was a review of several studies. Just 3 of them included women with bleeding disorders. And all reported poorer scores in all domains compared to the general population. The biggest impact was on every feature of everyday life, as you can see there. These were the scores. So in the red are the women with bleeding disorders, and in the black are the general population. So in all domains, it was worse if you had a bleeding disorder. And this was a model of quality of life related to heavy menstrual period that was in a paper by Madison in 2010. And the shaded areas was what was already recognized that was captured in quality of life questionnaires, such as the quantity of bleeding, the fact that they pass large clots, but in the white areas, the ones that aren't shaded, were features of heavy menstrual bleeding that were not being captured. And this was getting into issues of fear, of social embarrassment, women having a ritual procedure, getting ready for every month to have heavy bleeding for a week or so. So getting prepared mentally, buying their products, making sure they had them with them, arranging their activities around this, making sure they were always close to a washroom, etc. You can see that there. So looking at validated, focused health-related outcome measures for women with heavy bleeding, in 2007 in the UK, the definition of heavy menstrual bleeding was changed. Instead of related to the amount of bleeding, it was changed to menstrual blood loss, which interferes with a woman's physical, emotional, social, and quality of life, in which can occur alone or in combination with other symptoms. Over the next 4 years, in the United States and the UK, they stated that any intervention or clinical trials related to heavy menstrual bleeding needed to measure quality of life and not just focus on menstrual blood loss. And then in 2015, since the last Code Rouge, there was developed a validated disease-specific questionnaire for heavy menstrual bleeding questionnaire, but it was developed for women over the age of 18, and that was Dr. Madison who included those questions that were being omitted from previous questionnaires. So focused quality of life questionnaires for patients with von Willebrand's disease. So there's more of these than the patients with all bleeding disorders. So in type 1 von Willebrand's, one paper said up to 86% of women had pain with their periods. And in one study, 50% of women had severe pain. And in another study, a third of girls had severe pain with their periods. In von Willebrand's disease, this is referring to Barr's study, which came out in 2003, again from Hamilton. And he looked at males and females and came up with the results that women were more impaired in emotions, pain, and thought than men, and type 2 was more severe than type 1. They lost time in school compared to the general population, and we've heard that their quality of life was similar to hemophilia patients with HIV infection. This just looks at women with heavy menstrual bleeding, and on the side here is the percent. So if you look at 50%, these domains are related to emotions, losing time from work or school. Looking at focused questionnaires at women with bleeding disorders. So again, the issue of losing time from work and school. Women with von Willebrand's disease seem to be more impaired than other bleeding disorders. In some studies, had more severe pain during menstruation compared to women with platelet dysfunction. And looking at quality of life and outcomes after treatment, I'll just briefly go over this. There has been some studies to show there is improvement in quality of life after endometrial ablation, and it seems to be the same whether you have an underlying bleeding disorder or not. Looking at quality of life specifically in young people, there are some studies, and they definitely have impaired quality of life and often, again, related to heavy menstrual bleeding. Another study compared young people with hemophilia and von Willebrand's disease, and in the physical component, the women and girls did score lower. A recent study looked at men and women with hereditary and acquired bleeding disorder, and they compared, the comparison was interestingly to their siblings who didn't have a bleeding disorder and to blood donors in the general public, and they found that young people had the same quality of life, but older people, it was a lower quality of life. And again, I wonder if that's related to the onset of heavy menstrual bleeding. Just looking at this is quality of life in adolescence during menstruation. So the black is the heavy periods with a high PBAC score, and the higher the black, the more it's a negative impact. So it's absentee from being absent from school, social activities, sleepovers, and travel. So a lot we still don't know about the quality of life in women and girls with bleeding disorders and no menstrual bleeding. Is that worse than the general population? We don't know if the quality of life of women and girls with bleeding disorders and heavy menstrual bleeding is worse than women and girls with heavy menstrual bleeding. So I'll just finish off with some slides, just a few slides from Ashley Chopek. So thanks to her for giving these to me. And this is a study, senior author Vicki Price. And it's developing and validating an adolescent heavy menstrual bleeding questionnaire and trying to extend the MBQ to women who are under the age of 18. So they developed the questionnaire, validated the questionnaire, and the participants were involved with focus groups, and the main themes that they came up with was concerns about breakthrough bleeding, school absenteeism, fatigue, and bullying. And to validate it, they've gone to the IWK in Halifax and the Stollery Hospital in Edmonton. They had 60 participants, and they had controls. And the next step is to for the recruitment, phase 2 for the final validation is hoped to be completed this summer. So conclusions, the quality of life is an essential consideration for women with bleeding disorders. Reduced quality of life is associated with heavy menstrual bleeding and iron deficiency anemia. And although there is a validated health-related quality of life instrument for women with heavy menstrual bleeding, we don't have specifically one for women with bleeding disorders. And a very important advancement is the study underway with the adolescent MBQ. And just to recognize the number of Canadian researchers who have made a tremendous contribution to this area, and hopefully we will continue research in this area. Thanks.
Thank you, Dr. Robinson. Do we have some questions?
Hi, Sue. Thank you.
Thanks.
I always struggle in the clinic, and I think both of these things contribute to poor quality of life, but the intersection between pain and flow in women who have menorrhagia and bleeding disorders. And so I think we're really good at assessing flow and understanding and having a lot of treatments for that. I feel a little less comfortable with pain, and sure enough, the nonsteroidals are helpful in most cases. But are we really addressing, and should we be looking further at a more in-depth assessment of pain, whether in our quality of life tools or separately in these women? Because I think that if we do a wonderful job of controlling their flow and treat their iron deficiency, maybe we still have something left over to do.
Yeah. I don't really have a lot of answers to that, definitely. And, I think there are those patients that will not go near a nonsteroidal anti-inflammatory because of their bleeding disorder. So I do think we struggle. I mean, that intersection with the gynecologist is essential. But yes, I think we need to go a long way to improve it.
Just to make a further comment, we know that a certain percentage of girls or women that have menorrhagia have associated pain because of the flow. What we actually don't know is how many women with bleeding disorders have pain without heavy flow, and what percentage of the pain is associated with the heavy flow. I don't know those statistics exist even. And that brings up a good idea, is to survey whether pain alone could be, and what percentage of pain is associated with menorrhagia, and how good we are at assessing that and treating that. I think that's a really important point.
Yeah, and I think our clinic has recently become sensitized to pelvic floor dysfunction and a whole field of things
Right.
and other tools that we may not be used to in medicine that might help these women with their quality of life. So,
Thank you.
Thank you.
Hi, my question actually follows nicely. I'm Marianne Jameson. I'm a gynecologist. I deal with adolescents and adults in Kingston. I would follow up with, we know that women with inherited bleeding disorders are more likely to have other gynecologic conditions, including endometriosis, and that can happen in adolescence. And so I think that thinking about other causes of dysmenorrhea or menstrual cramping, it behooves us to do that. But also, it's my opinion that too many of your patients, or our patients with women in with inherited bleeding disorders, are told not to take nonsteroidal anti-inflammatories. And it's my opinion that you're denying them, or we're denying them, or they're denying themselves a really good medication that will probably, in most cases, not increase the bleeding that much, or at least not worth, in a way that's worth denying them. And that those medications, whether it's ibuprofen, naproxen, mefenamic acid, ketorolac, whatever, that and for 1 or 2 days a month, proactively should be able to take.
Yeah,
my
thank you.
opinion.
I agree very much.
And just a comment to that as well is that we actually think that there may be some advantage of anti-inflammatories in treating menorrhagia because of the shift in prostaglandin, and specifically uterine prostaglandins. So I would agree with the comment that I think it's still something that we don't recommend routinely for fear that it's going to induce other bleeding symptoms in a patient with an already diagnosed bleeding disorder. But I agree, I don't think we know enough to make firm recommendations. And case by case, we sometimes do allow anti-inflammatories in patients, especially with the mild bleeding disorders, and especially if it's a short duration. So
Thank you.